Hi guys, so this is just kind of a little talk that I feel that I wish I had before I went to starting F1. So you've all done finals, you've all done really, really well, and you know all the knowledge and stuff. However, being an F1 isn't really about knowing all the intricacies and stuff. You've got seniors to bounce off ideas and consultants to tell you exactly what to do. So I thought I'd just like do a little presentation about what sort of things you get asked to do over the phone and over a night or on call. So ATSP, ask to see a patient. The nurse will ask you to see every patient. You just have to try and understand which is what you need to see and what you can kind of leave for a bit later. So the most important thing is you've got loads of time. Don't feel you have to rush off from the mess or wherever you are to go see a patient immediately. Give it a minute, check the notes, bring the patient up on your own screen. Also on the phone, ask the nurse a couple of questions as well. Don't just be like, yes, I'm going to go and see you straight away. Are they stable? Why are they worried? Why have they got to a point where they think they need to come and ask you to come and look at this patient? On a call as well, you'll get bleeped, you know, tens of times an hour. It's really important just to take one bleep at a time and work methodically through it. At the end of an on-call, you've always got someone to hand over to. So, and you get handed over jobs and you hand over jobs. It's just this part and parcel of being an F1 really. So when I'm checking through the notes, always making sure you look at the background, look at their observations, how ill are they, and what's changed the observations is really important. Sometimes a nurse will bleep you saying, oh, this person's using a 4, can you come see them now? When actually during the day they've been using a 5 and a 6, and today this is the best they've been. So it's good just to get a gauge of where they're at. And medications are always important. A lot of the problems that you see in hospital are actually caused by us. So looking at those is good. So I'm not going to teach you how to suck eggs. This is all the basic stuff. Whenever you go see a patient, A, B, C, D, E, just do it always. It means you can't really go wrong. And also when you're in a high stress situation, can always resort back to like these simple skills. You can just get the job done nice and quickly and move on to the next bleep. So something that I've been asked about a lot is vomiting. Initially, it's quite scary as well because a patient it's quite hard for a nurse to look after someone who's vomiting a lot as well. Few things you want to ask yourself: is it fecal vomiting? That's the sort of thing you need to rule out on an on-call. Because if they're obstructed, you need to get the surgical team involved nice and quickly. Always ask a few questions. When did they last open the bowel? And you know, are they passing flatus? Are they farting? If they're doing those things, then you can be less concerned. If they haven't gone to the toilet for a few days, so that the old biddy on the DME ward, but she's been farting throughout the day, then you can kind of be less worried about it. Antiemetics, sort of stuff that you'd be prescribing, tens of times a day. Just remember, if someone's vomiting, they can't take it orally. And some people who are vomiting as well and become a bit hypotensive and are just unwell, they're normally pretty shut down. So it's quite hard sometimes to get a cannula in quickly. Don't be afraid just to prescribe things IM, just so the patient can get it straight away and get relief from their symptoms. I got asked a lot of which sort of antiemetic is best to use. I think probably the best one to use before if you're not too sure, is to go for ondansetron. Because just there's less interactions and it seems to work fairly well. Cyclizine is really popular in the hospital, especially at Arrow, but I'd be aware of it because you're treating sort of the elderly population and there's always a worry that they've got an element of heart failure. Obstruction, like I said before, this is a sort of thing that you need to kind of pick up and make sure you refer to the surgeons nice and quickly. Like I said before, passing gas and flatus is an important symptom. It can be kind of awkward and weird asking an old lady if they've farted today or not, but it's an important thing you need to add into your histories. If you're concerned, just do an abdo x-ray. You're not going to get shouted at for over investigating a patient. I think I'll be the first to admit that abdo x-rays I'm not very good at interpreting them. So it's always good to get a senior to have a look at them as well. It's quite hard to say, is this obstructive or is this just gas in the bowel? We all know how to treat it: drip and suck, make them know by mouth, Ryle's tube, a catheter, and fluids. A Ryle's tube is basically just a thick NG. Some people say to put an NG tube down, but a lot of NG tubes are only for feeding and they won't be able to provide that sort of gauge to get stuff back off. Yeah, and Reg is always asking you to do a VBG, just so they can see the lactate. There's blood in the toilet. You get calls about this all the time. Someone's passed dark red stool or dark black stool. You need to think first. Again, we go back to what I said originally. Check the medications. A lot of the time, these patients are on iron tablets, so you need to understand whether this is iron or it is actually proper melena. Always good when you go see those patients as well. Ring over the phone, ask the nurses if they can to try and get a set of bloods done. Obviously HB to see if they know they're becoming more anemic. Urea is important, and their clotting factors. And get a group and screen done, because in most hospitals you require 2 groups and screens to make sure that they give the patient the right blood. PR exams, they are what they are. You just have to do them. Everyone says, you know, don't put your finger in it and all that sort of stuff, but you do need to do them. It's important. The golden rule as well with people who are bleeding from the back passages: are they hemodynamically unstable? If the blood pressure is dropping and they become a bit more tachycardic, then you have to be more worried about them. And on call, I'd escalate directly to a reg. Just don't panic about having to do stuff yourself. Go on a fact-finding mission. Go to the patient. Get as much information as you can. Take the bloods, and then go find your reg. Fluids, the wonderful world of fluids. You get taught how to do fluids all the way through medical school. Doing them in practices, this can be a bit different. The surgeons like to make sure that the sodium in and sodium out and the fluid level throughout the day is well maintained. However, in medicine, I've found that the surgeon would be like, or the consultant would be like, give them fluids overnight and just prescribe a 12-hour bag. People always ask as well, Hartmann's or saline. It's not too important. All I think is remember that Hartmann's is closer to blood and saline's more salty. So if someone's become got their sodium level a little bit too high, then maybe it's time to use Hartmann's. But if someone's become to a point where they've become hyperkalemic, then be careful of Hartmann's because it has sodium in it. Nurses will always ask you as well if they've prescribed fluids overnight. I don't drink a bag of a litre of fluid overnight. Maybe the patient doesn't need it as well. It's good to probably rationalise people's fluids overnight, because we always seem to overhydrate people and then they become overloaded. Chest pain, simple stuff. Socrates, make sure you go through your pain stuff. Even if you're not sure if this is chest pain or not, cardiac chest pain, it's always good to, run through everything, and then you can always escalate to a senior and they can tell you, actually, have you asked this question? Have you asked that? It's always important. Always ask for an ECG. Again, that's a sort of a test you can ask on over the phone as well. So when the nurse is ringing you up, really worried and concerned, this person's got new chest pain, which is actually just reflux, get them to do an ECG. So then by the time you get down there, you've already got that thing to check and have a look over and see, is there ST elevation, all that sort of stuff. A massive tip that I've learned being an F1 as well is never go off one piece of paper. Always ask for repeats. Always ask for the old stuff. So if someone's had an ECG done on admission and an ECG now, other changes. That's the important thing. Like some people have a left bundle branch block and they live with it. But if it's a new left bundle branch block, then it's something that you might need to think about escalating. If you look at an ECG and they haven't got the repeats and it looks a bit weird to you, even if you can't really describe why it looks weird to you, treat it as an NSTEMI until otherwise proven. So take your drops and escalate to a reg. AF, something you see a lot. And also I had to deal with this my first on call as well. Someone went into AF and I didn't really know what to do. It's always good to understand first, again, are they hemodynamically unstable? If they're hemodynamically unstable and an AF, that needs to go straight to a reg because they may need cardioverting. If they're hemodynamically stable and you go and see them, it's always good to see why. The good question is why they're in AF. So it could be because they're septic, could be because they need fluids, could because they had a PE, could just because they're anxious, could because they've missed their medication that day. So it's always, I wouldn't go jumping straight in and giving prasoprolol straight away and try and slowing them down. Have a look about what else could be causing this first. I say as an F1, especially in the first few months, But don't be too afraid of giving a beta blocker straight away. Well, once you've ruled out the other things, don't be afraid of giving a beta blocker. But I think when you get to the point of needing to load digoxin because a patient can't have a beta blocker because of asthma or another reason, again, I think it's good to let your reg know about the patient. They'd be more than happy to come and help you. And don't forget to repeat the ECG and closely monitor the patient afterwards, making sure that your medication or your treatment is starting to work. Seizures, always really scary when you see your first seizure on the ward for the first time and you're the only one there. 9 times out of 10, the seizure will self-terminate. So when a nurse calls you saying a patient's had a seizure, again, take your time. I'd even say, if you know the patient, great. If not, we'll go off the ward, ask the nurse on the phone, have they got a history of seizures? Have they missed their medication today is always a common thing. And over the phone, get them to prep the IM lorazepam or whatever your trust has as their medication to stop seizures. Ask the nurse to go prep it. So then when you're there, you can be ready for it if you need to do something about it. If you're concerned as well, so my first ever MET call was me on my own. I first arrived at a seizure and I was the first one there. I think it's always good as well. I'm very grateful to have senior support around me. If the patient starts to lose their airway or you become more and more concerned about them, then no one's going to shout at you saying, no, I need to escalate this to a MET call. I need to go ring the anaesthetist and making sure their airway is safe. No one's going to be angry about you being safe. Important for seizures as well. Another thing you can ask for over the phone is go ask the nurse to go check the BMs. A lot of seizures are caused by hypoglycemia, so it's really good to have a look at those. DKA, we've all been tested on DKA in the past. Important to make sure, so DKA is only when those 3 things on the screen there have been completed. So the BM's over 11, the ketones is greater than 3, and the pH is less than 7.3. Every single trust in the country will have a DKA pathway. Again, it's important not to panic at that moment when this person needs treatment. Is go and have a look at the DKA pathway and just what I do is I print everything off and then I go through tick listing what I need to do. So get cannulas in them. You can always get ask the nurse to help you. Or you can always put a ring your reg, and as you're at the patient's bedside, put the 2 cannulas in, start the fluid going, and then follow the treatment algorithm that will be there for you, and hopefully the senior help will be there and you can sort them out. Falls, again, a very, very common F1 thing you get asked to do. Little old ladies falling over on the DME ward again, even though you told her countless times throughout the day to stay in the bed. Important to ask over the phone, how have they fallen? Have they completely collapsed, or have they 9 times out of 10, have they slumped down? A lot of patients as well start to feel a bit lightheaded having a vasovagal and they'll sit down. So, and then they'll ring you saying, can you come do a falls review? Remember your red flags for falls and when you need a CT head. So blood thinners, a lot of patients are on a DOAC. If they've fallen over and they think they've banged their head, book a CT head. No one's going to be angry. They can always cancel the referral, but it's good to put it in straight away. Why they fall is always important, but normally on an on-call, when it's just you, it's just sorting the patient out and making sure nothing acute has gone wrong with the patient. Check for bony tenderness is always important. Check down the spine, check the hips, and check for any bruising and cuts. And then ask the nurses to do a couple of neuro-obs afterwards. So that's, they check their consciousness level for a few times after that. And that can, again, put your mind at rest and make sure you haven't missed anything. With falls as well, what's key is good documentation. Writing down what you've seen in the patient. Where are the cuts? How big are the bruises? Have they got any lumpiness on their heads? All that sort of stuff. It's just all really good practice, really. We kind of went through that, didn't we? Yeah. Lying and standing blood pressures. Again, that's something that you can ask over the phone to do, or not really on on-call, but can ask. Like day team to review lying and standing blood pressures is always good practice, I think. Hyperkalemia. I was speaking to Brad beforehand before the talk. Altering electrolytes and managing people's potassium, sodium, calcium, all that sort of stuff. It seems to be predominantly an F1 job. However, the one you need to be most careful of is hyperkalemia, as you know. Again, like DKA, every trust will have some sort of guideline for this about what they do and when they do. At Arrow, they've got a really good online system. So if any of you guys are there, just you see a patient with a high potassium, just look it up. It's all there. If you're worried, print it off and you can go through it. The classic treatment is 10 units of rapid in 10% glucose over 10 minutes. It works pretty well. Salbutamol nebs, they don't really move it down by much. Might move down like 0.1 or 0.2 or 0.3, but I think the insulin dextrose is the mainstay of treatment. You get an ECG as well, again, over the phone. Ask the nurse to do an ECG. If they've got any ECG changes, so tented T waves and all that sort of stuff, then again, you need to start escalating that sort of stuff to your senior. They might need to be on a monitored bed, and you'll have to give calcium gluconate, which sometimes on some wards they can be a bit iffy about giving. Haematuria, again, the nurse calls you up, doc, there's blood in the catheter bag. Questions you need to ask is, what sort of blood is it? Are they passing blood round the catheter? Has a catheter just been inserted? Was it a traumatic insertion? Common things like that. It sounds strange as well, but they'll just reply to you, there's blood in the catheter. But you need to know what sort. Is it sort of like really dark red, like a really strong red wine, or is it more like a rosé? Is it a bit lighter? It sounds a bit weird, but you kind of understand. Then you kind of understand, is it proper blood? Are they really bleeding out of the catheter, or are they just, is it just a bit of leftover hematuria? You always get called a lot to block catheters. Again, over the phone, because you'll have 101 jobs to do. Ask the nurse, have they tried flushing it? Have they tried deflating the balloon, inflating the balloon? And it sounds strange. Sometimes just giving it a bit of a wiggle, pushing it in a little bit, pulling it out a little bit, just can sometimes get the flow moving, and you can start getting the catheter to drain. If they're passing big clots in the catheter, then it's always good to speak to the urology SHO about putting a three-way catheter in. If you're not too experienced putting catheters in, I don't think I've done too many myself. It's always good to speak to someone who's put a three-way in many times, like the SHO. Low GCS. I got called to this quite a few times at night. A patient had a low GCS. Actually, you just go to the patient, they're just sleeping. But when someone actually has a low GCS, always get someone to check the glucose straight away over the phone. And then again, start from the beginning, A, B, C, D, E. You can't really go too wrong as long as you go through those things and you think something's changed. Just restart, like you've done 101 times in simulation. So I've written up there on the screen some things that cause a bit of low GCS. Like I said before, if someone gives Zopiclone, like a high dose of Zopiclone to an old man or an old lady overnight, it can knock them for 6. It really can. Alcohol withdrawal, pretty commonplace in Liverpool. A lot of places have complex pathways and all that sort of stuff. If it's really complex and long, read it through, print it off, it'll be fine. Pabrinex is your mainstay of treatment, so you want to get it up. You get a lot of time patients refuse and don't want the Pabrinex. If they really don't want it and you really can't make them do it, then thiamine 3 times a day is okay. Don't forget to refer to substance misuse, and if they've got a paper chart so the nurse can give the Librium to the Librium pathways, and that's always good to fill out on your own call, so the nurse doesn't keep bleeping you back saying, oh, this person's still not very well, they're still trying to leave the ward, they're still really agitated. It's good just to fill the pathway in, then the nurse has got that buffer so they can act upon it before having to call you about it and then getting you to come and review them again. Confusion. Most people over the age of 75 come in, and they'll come in with a history of an infection of some sort, and it'll be written in the notes, query new confusion. It's always important to rule out infection from it. Do a urine dip, get a chest X-ray, look at their obs. Have they been passing like bowel? Have they been constipated a few days? That for some reason likes to send old people a bit loopy sometimes. And you always got to think of sepsis as well. I've seen that sepsis is not as barn door as I thought it was during my time before. I've seen patients that have a very mild temperature, and you think about, oh, we'll just do some blood cultures on them just for routine almost, and they come back and they're growing Staph aureus. So I think have a really low threshold. If you think overnight as well, or you think this patient's unwell, or you're not too sure, and you start antibiotics, no one's going to be upset that you've started antibiotics. Just because if you can reason, oh, I think it could have been sepsis, I think it could have been, even though in the morning people think otherwise, no one's going to get angry at you for doing that sort of stuff. So shortness of breath, we're getting to the part of the talk now. We're going to be talking about COVID in a minute. It's a little bit outdated what I've written in this presentation. I hope you're all right with that. So shortness of breath, again, a really, really common presentation, especially when you do, I don't know where you guys were working, but if you're working at Aintree, you might do F1, F1 and A&E, but then a lot of other hospitals have F1s down in admissions. So again, typical history, go through it. If there's any pain, go through your Socrates, look through their past medical notes. Have they got any history of COPD and heart failure? They are the most common things. So you need to make sure you think of those things first. Smoking's always good to get a good social history as well. Do they drink? Do they smoke? Just normal things. Something that I've learned as well is always check the calves. It's now part of my sort of routine examination. Listen to the heart, listen to the chest, feel the tummy, making sure nothing's, tender. And then I have a squeeze of their calves, making sure they haven't got like a very subtle DVT that they're just hiding. And they said, oh, my legs have always been like this. They've always been a bit sore, when they've actually got a good going thrombosis. Good investigations to always be done even this is just for shortness of breath, but it kind of stays for anyone that you go see and you're unsure of what could be wrong with them. So if they've got a low oxygen stats, give them oxygen. Think about if they're a retainer as well, look back over the notes, their COPD, aim different sats. Take bloods off patients, take an ABG. If you don't think an ABG is needed, take a VBG. Start spiking, take some cultures, and if they've got a new oxygen requirement and they've been previously healthy, it could be coronavirus. Even though places in Merseyside are going down the number of cases, it's always need to be at the front of your mind, even if people are getting vaccinated. DVT and PE, this I think is actually much more common than I was expecting. Every other person seems to come in with the PE at the moment. Don't know if that's COVID related. Calculate a well score. It's not just for an academic reason. It's always good to try and sell a CTPA to radiology if you've got say your well score is high and the patient's got a couple of other risk factors, and then it kind of forces their hand in saying, yes, we can do that CTPA urgently instead of having to wait until the morning. If you think someone's got a PE and they're scoring highly, you start them on treatment dose, low molecular weight heparin, straight away. There are two sort of treatment regimes you can do. You can do the once only dose, which is okay. But I personally like the BD dose as well. It has got less of that risk factor. So you could start someone on a BD dose, treatment dose, noxaparin, and if in the morning someone decides actually they don't need this, you haven't given them a whacking great dose of heparin before the morning ward round, and you decrease their risk of bleeding. Pulmonary edema, I've seen this quite a bit as well. Flash pulmonary edema happens quite a lot to a couple of ill patients, and cardiorenal syndrome is also quite a common thing, and I think it's the hardest thing to deal with as an F1. Someone with brand new, if someone's been doing well throughout the day, and then suddenly has a massive new oxygen requirement and they look a bit edematous, I wouldn't wait too long. I'd make sure I let my reg know. I'd give them 40 milligrams of furosemide IV straight away. It's actually a wonder drug sometimes that someone's had flash pulmonary edema. Their stats will be in the mid 70s and you'll think they'll be peri-arrest, and you give them 40 milligrams and they'll be up to 88-90% sats in about 15 minutes. Makes you feel quite good that you're treating someone as well. Yeah, coronavirus is coming. I think coronavirus has been, yeah, sorry, a bit out of date some of this stuff. So COVID, there's not really a full-on treatment for it at the moment. Dexamethasone is being used in trial. Well, it's been trialed and it's part of the recovery trial, and it's been shown to decrease mortality, but only patients that have been started on oxygen. A lot of the time, people will be like, "Oh, why isn't my dad on or mum on dexamethasone?" And you have to explain to them, actually, no, it's not the best care at the moment, because it increases their chance of having a glycemic episode, which we've seen quite a lot at Arrow, especially. I've seen a couple of patients that are type 2 diabetic and then gone to HHS because we've given them so much dex. But the most important thing for you guys, I think for F1s as well, is looking after yourself is, again, the most important thing. But I know most people will be vaccinated, but don't forget, you're seeing one patient, then you're seeing another, and you're still seeing another. I think the people that are super spreaders are us in the hospital. You see it at the moment, like, you know, one ward will go down as all the staff on that ward will just give COVID to all the patients, or give the COVID to all themselves. So washing your hands properly and wearing the right gear is always important. Met calls. I'm not sure if every hospital has a Met team, but I think most of them do in the Northwest. Again, Met calls mean someone that's musing over a 7. It's important to understand, like, have they been doing this all day? A lot of the time, people recurrently Met call throughout the night, which can be a bit annoying, but I guess it's there for a reason. Again, you've got 15 minutes to get there, so you don't need to drop everything you're doing and rush straight there. If you've got some time in the mess and you're on the computer already, look up on the notes. It's really helpful for the reg as well, who will be leading most of these medical stuff, to, like, you know, ask them, well, you better tell the reg, like, what's changed. Has their BP dropped? Has they become more tachycardic? Have they had a new oxygen requirement? Or had they just been using a 6 all day and then suddenly just moved to 7 because they become slightly less alert? Anything like that. A lot of the time, as an F1, you are the first person at a Met call. Think, again, you're not there to cure the world. You're not House. You're there just on a fact-finding mission. You've got to, you know, think, what's needed? Have they got cannula in? Do I think they need a cannula straight away? Like, do those sort of things. Check the patient's okay. Is their oxygen stats really low? Maybe put them on a non-rebreather. It's just, you start in the initial management and getting a few facts here and there. It's just important. Cardiac arrest, which I actually haven't written on here. Don't forget, before your cardiac arrest, I think this is going to be the mainstay of cardiac arrest sort of initiation for maybe even by the time that you guys are getting deep into your F1, sorry, is that when you get to a Met call, get your full PPE on first. It's always about protecting yourself. So get your proper masks on, get your full gown on, and then start going through the whole system. At a cardiac arrest, it's very different to a Met call. There's much more people. Again, as an F1, your job will be get access, or it'll be do compressions. It won't be stand back and lead everything. Like I said before, I think the main point of this talk is not to be too afraid. It can be hard at times, but being an F1 is a really, really good job. Just the important thing is not to be rushing around like a madman or a madwoman, going from patient to patient and doing everything, you know, to like 70% your standard. I think, you know, take your time. There are very few things that need actioning straight away. Most things can wait a little bit. No patient's going to imminently die if you're not there within the first 30 seconds of someone bleeping you. But I think, like, the most important thing as an F1 is don't forget lunch. Everyone thinks that you work until 5 o'clock without a break. That's just going to force yourself to make more errors. Go to the mess, have 20 minutes. Even if you have to stay 20 minutes later at the end, I think it's good just to give yourself that headspace, because it can be stressful at times, but it is really enjoyable. That's all for me, guys. Thanks a lot for listening to me ramble for 45 minutes or so. If you've got any questions or anything, or you think that any other talks might be quite useful, I'm more than happy to help. Something that I thought would be quite useful as well, I spoke to Brad beforehand, was electrolytes, I mentioned before. Just because that sort of stuff you see on ward round all the time, their calcium's high, what do you do? Their phosphate's low. at what point do you start treatment? I think as an F1 when I first started, I got quite worried about that. And one thing I haven't put in this talk, which I will give to you at some point, or someone will give to you, is the agitated patient. So like you get called up, Arthur, he's 65, he's kicking off, he wants to leave the ward, he's threatening staff. What do you do in that situation? You have to go there. It's really difficult. Going to see a patient that's kicking off like that, a lot of the time, by the time you get there, they normally calm down a bit. But there's always important things that I've already had to, as an F1, had to rapid trank someone to get the heavies in. But I think as an F1, if the nursing staff mentioned that there's risk to themselves or the patient's being violent at all, encourage them to get the security in, get the heavies, get the patient restrained if need to. Most people will calm down. It's very rare you have to intervene and stuff. Again, that's something we'll talk about later. So yeah, cheers guys. Thanks a lot.
Thanks very much, Ollie. Really appreciate that. Thanks everyone for coming. It'd be absolutely great if, you know, Ollie's given up his time today. If you can all fill out the feedback form, and then I'll collate all the feedback together for his CV. So it's the feedback form is on the event. It's just a Survey Monkey. So if you can just all fill it out, that'd be great. And then we may potentially get another talk going in the new year about some electrolytes and some crazy.
Cheers, guys. Yeah, please fill out the feedback form, guys. That'd be great. Thanks a lot. Cheers, Brad.
Cheers, guys. Thanks very much.
Thanks very much.